morning, good afternoon, depending where you are. We have a really good turnout today. Thank you for taking time out of what I expect is a busy day for you. I hope we have a very good and interactive session, and you come away with some new knowledge. This topic today, we all know VQ scanning. We all know the various ventilation agents, particularly Technegas. That's basically the standard of care for most of Canada for doing our VQ scans. Been doing them for years. One of the things we suffer with VQ scans in terms of when we get taken to task by the radiologist is that, you know, we're not looking at the arteries, we're looking at the physiology, but we know they're equivalent, particularly with SPECT CT. And what we're going to hear today from three very distinguished lecturers is some new ideas on how potentially this particular agent and our techniques can aid in things other than pulmonary embolism. I think it's very interesting. We've been working on this in Halifax, and you'll hear from one of our researchers here leading the team about what we found and some very interesting ideas. I'd ask you to submit your questions as they come to you so you don't forget them. We are going to hold questions till the end, and then we will hopefully have a really good panel dialogue. So without further ado, I'll move on to our first speaker. It's Dr. Geoff Maksym, who's a professor here at Dalhousie in the Biomedical Engineering Department. He leads the Cell and Lung Mechanics Laboratory. He trained at McGill and as well as at the Harvard School of Public Health. Research interests include computational modeling of respiratory function, including multi-branched airway tree mechanics. I've had the privilege of working with Dr. Maksym over the last few years on this, and we always say in medicine it's always neat to get different perspectives. Usually it's just from one of our medical colleagues, but this from biomedical, it's a great learning experience. And when it talks about computational modeling, it's very, very interesting and also way over my head. He's the co-founder of Thoracis Montreal, which develops respiratory measurement technologies used for research and clinical. He's well published and well regarded in the Canadian respiratory and biomedical engineering area. And I'm going to turn it over to Geoff to tell us about some of the interesting stuff we've been doing here. Go ahead, Dr. Maksym.
Thank you, Dr. Ross, for that kind introduction. All right, waiting for my screen to share, and
you're looking good on my end here, I think. Or am I? There we go. Now we're good. She just popped through.
Showing the full slideshow. Okay, so
yeah.
Okay, great.
If you don't mind, it should be the other tab, Dr. Maksym. Yes.
There you go.
Okay. Thanks, Hamidi.
Yep. Okay. Thank you very much again. So I'm going to be talking about a project where we're trying to use VSPECT and hopefully later QSPECT to see what it can measure post-lung transplant. This are my disclosures. I have funding from NSERC, also Cyclomedica, Lung Association CHR, and I'm a scientific advisor for Thoracis, but not remunerated. So chronic lung allograft dysfunction, it's the leading cause of lung transplant graft failure after a year. Median survival is not great, 6.7 years, with 59% people surviving 5 years. And it's defined as a sustained loss of forced expiratory volume in 1 second. So it's a physiological definition of greater than 20% from your best post-lung trans value. Usually you have lung transplant, your FEV1 is actually poor due to the inflammation and recovery, but it recovers over a several month period. And then your best FEV1 is used as a reference to track the patients whether or not they are getting this disease, chronic lung allograft dysfunction. And it presents more commonly as an obstructive form, also known as bronchiolitis syndrome, and less common as restrictive forms, and it can be mixed, and it can switch from one to the other. And CT imaging has been used, and it features septal thickening, ground glass nodules, consolidation, but the features that you see in CT tend to overlap other pathologies. So I'm going to be talking about some cases that are either suspected CLAD, which means they have an FEV1 of less than 90% for 2 times over 3 weeks, or even full-blown CLAD, so their FEV1 or FEC is less than 80% also for greater than 3 weeks. And I only have obstructive CLAD patients in my group. So what we've done is we've collected some patients. We're working on, I think, 10 now and hoping to get up to 15. They get low-dose CT, V-SPECT, and Q-SPECT. And so we use Technegas as an inhaler, and you're familiar with that, and there's some images here of what they look like. So they undergo those measurements every 6 to 9 months. That was the plan, actually, but then COVID hit, and perhaps fortunately we have a longer time frame between our second and third visits for some of our patients, and we're going to hopefully recruit all of our patients that we had before, but we've only started that third visit for most of them. So we do our SPECT CT following CANM-ACMN guidelines, and it's written here how much we inhale according to the guidelines. And we do a low dose CT for the first scan, but we do ultra low dose for every scan after the second visit, the third visit, and so on. We do V-SPECT imaging on a Philips device. We also measure spirometry and a technique called oscillometry, but I won't be talking about that today. So here's a CT image, and here's a V-SPECT image cross-section. Our image analysis is that we load the CT, we try to figure out where the chest wall is. We're trying to figure out what the volume of the lung is that's being ventilated and the volume that's not being ventilated, assuming all of that is contained within the chest wall, excluding, of course, the heart. So in order to get that volume, and we create masks, as you can see on the right, we isolate the lungs, we remove the trachea and the main stem bronchi, and we create a binary mask. So now that represents our volume of the patient, of the lung. Then we have to do registration between our CT and our SPECT imaging. And we've tried rigid and affine to improve that registration. They're both attempted at the same volume, and they're both done supine. So these are all of our subjects. And you can see there's quite a bit of disparity. These are cross-section coronal slices of patients normalized to dose. So we've done something a little fancy. Instead of just taking the raw data, we know what the dose is from our dosimetry when we're calibrating the device or the inhalation of the patient for the patient. And then we normalize to that number. And you can see that in some patients, you're getting these very bright places and huge regions of the lung where gas is not going. So the technique is they inhale, and when they're imaged over 10 minutes just at normal breathing. And we do that to increase the sensitivity to where the Technegas has landed. All right, here's another way to look at them. These are just with white background. It's 8 patients here. And I'm looking at them here just because I like this image a little better. If we're looking at coronal slices, you can see it's kind of mottled in some of the patients. Some of them seem to have some back to front or gravity dependent ventilation perhaps, some down by the diaphragm. And these 2 patients here are the only 2 patients. One of them is 10%, a greater than 10% fall in FEV1, and the other one is a greater than 20% fall in FEV1. So the patient 3 has suspected CLAD, patient 4 has full-blown CLAD by spirometry. If we compare those patients, I think it might be useful to look at them. They're about the same age, same weight, same height, different number of years since they've had a transplant. Patient 3 is doing very well at 12 years, patient 4 at 3 years and 4 months. We have their best FVCs and FEV1, so we can compute their ratios. And even though patient 3 here doesn't have very great FEV1 over FVCs, they're still very stable after 12 years, right? And this patient has crossed from non-CLAD to at risk of CLAD with that 11% fall. And this patient, unfortunately, has a 66% fall in FEV1, which is a tremendous decline. I didn't want to show you that. So imaging metrics. From our images, we're going to use 2 global measurements of what we're seeing. And we're going to look at the coefficient of variation, which is the standard deviation of the intensity from all slices. So the entire volume within that mask divided by the mean intensity. that calculates the heterogeneity. If they have a lot of very bright pixels, a lot of very dark regions, you're going to have a large standard deviation. If it's all the same ventilation, uniform ventilation, standard deviation would be 0. Another measure is the ventilation defect percentage. There we define the volume that's below a threshold intensity. And so if it's dark, like really black, the Technegas hasn't made it to those regions of the lung. And that's the defect volume. And so the percent of that volume divided by the total volume from the CT mask is giving us a percentage measure of how much of the lung volume is defective in terms of ventilation. So I'm going to show you a couple images. So subject A, that's the at-risk of CLAD person. And subject B is the one pretty far gone with CLAD, right? And you can see they're quite different, although there's quite a bit of modeling in this one. And if I here it's large ventilation at red, low ventilation at blue. And these are amplified to have the maximum intensity spread for every slice. So that's kind of exaggerates the heterogeneity when we're looking slice by slice. The same thing here, unfortunately in black and white, these are healthy patients, or at least patients who've had lung transplant who are otherwise healthy. This is a different way of looking at it, and it's a projection image. Projection images sort of average across, well, they do average across all the slices. And instead of that modeling we saw in an individual slice that was scaled to the maximum and minimum, it's a bit more muted when we do that. And same with the patient projection. And I'm giving you some numbers down below. So the coefficient of variation is 81% with a VDP of 9.1%. Remember, 0% is perfectly healthy, but no one has a 0%. Typically, Sarah might actually know the right numbers. 10 to 20% is within normal. But this is a fairly normal VDP. This VDP, 56%, is very high. So there's a lot of the lung is defective. If we look at across our subjects, now we have 8 subjects that have been currently analyzed, the coefficient of variation versus the percent drop in FEV1, it looks like there is a correlation, but it's highly driven by that one patient with that very high coefficient of variation. So we have to take it with a bit of grain of salt. And they weren't significant, at least at the P.05 level. They are significant at the P.1 level, however. And VDP is a similar sort of result. So the global measures, disappointingly perhaps, don't seem to compare to the FEV1. But when we look at the images themselves, I'm hoping you're seeing these movies, we can see that someone at 10% FEV1, there's a little hot spot here, there, and we're seeing some modeling. It's a bit gravity dependent. This one, on the other hand, we're seeing some very bright spots where the Technegas is deposited much more preferentially than the other regions. And we tend to see this in many of our subjects. I'm sorry if I'm going to flip back to this, but if you see the modeling here, you see the modeling here. Do we see modeling in this patient, patient 8? I don't have the data to present with whether that one's on the path towards CLAD in terms of our imaging metrics. But what we're seeing is that regionally, we're seeing big differences using SPECT CT between the healthy subjects, the close to CLAD, and the CLAD subjects. So I'll conclude with Technegas at the point of our study. We're hoping to find out whether or not those changes change with time. Our early data, which I didn't show, shows that, especially in those 2 patients, on our repeat visits, the ventilation, some of the defects grew in size, but more so, some of those hot spots became very bright. So perhaps the hot spots are something to look at. And it kind of makes sense. If the ventilation is not going to defective regions that easily, it's going to go preferentially to smaller, limited regions that they have left. But that remains to be seen if that can be a useful measure over time. So I'll conclude with COV and VDP were useful global measures, perhaps. We don't have the power yet to say so. They were significant only at the P.1. Heterogeneity was robust to the imaging methodology. In other words, we didn't actually need the chest wall. So we actually don't have to use CT if we're going to use COV. VDP, we were able to see growth of unventilated regions, although I didn't show it to you. So it might be sensitive to image methodology as well, because we have to choose what's not ventilated and what is using a threshold. Both show some correlation, although it wasn't at the p.05. The images did show strong regional characteristic heterogeneity in the patients that were at the risk of CLAD and with full CLAD that may be indicative or may be used as indicative of disease. And the hotspots are what we're excited about to analyze further. Thank you very much.
Thanks very much, Dr. Maksym. Appreciate it. Interesting. I think we'll move right on to our second presenter. This is Dr. Sarah Svenningsen from Hamilton, from McMaster. She is a Tier 2 Canadian Research Chair in Translational Pulmonary Imaging, as well as an Assistant Professor in the Division of Respirology at McMaster. She is as well an affiliated scientist with the Firestone Institute for Respiratory Health, as well as the Research Institute of St. Joe's in Hamilton. Dr. Svenningsen completed her PhD in medical biophysics at Western and also did a postdoctoral fellowship in complex airway disease at McMaster. Her research program focuses on the development and application of pulmonary imaging methods and measurements to help understand and evaluate and manage pulmonary disease. She's very well cited and published, and I look forward to hearing what she's been up to with this exciting topic.
Thank you very much, Dr. Ross, for that kind introduction. Just waiting to receive the share screen.
All right.
It won't be too long. It won't be too long. Just had to.
I'll let you know as soon as I see. In the meantime, I remind people, for any questions, certainly feel free to submit. And
We should be good to go.
All right, and you should see
Good.
my screen now.
we have it.
Okay, wonderful. Let me just get this out of the way somehow here. Okay, we should be good now. So again, thank you, Dr. Ross, for that kind introduction. It's an absolute pleasure to have this opportunity to speak to all of you today about our work on the prevalence and clinical relevance of abnormal ventilation quantified by Technegas SPECT in lung cancer patients prior to lung resection surgery. Shown here are my conflicts of interest, only one of which is relevant to this talk, and that's that I've received research grants to my institution from Cyclomedica. Okay, so lung cancer, a disease that we are all too familiar with, as it kills more than 21,000 Canadians annually, accounting for 26% of all cancer-related deaths in Canada. And curative intent lung resection surgery is the optimal treatment option for early stage lung cancer. However, postoperative pulmonary complications are frequent adverse events of curative intent resection surgery, with an incidence of around 15 to 40%. So 1 in 4 people who receive a resection will have a postoperative pulmonary complication. And these prevalent complications, they lead to substantial patient morbidity and mortality, and they have significant clinical and economic impact. And despite this impact, postoperative pulmonary complications remain to be inadequately predicted, and little effort is being directed towards identifying risk factors that can be modified prior to surgery to prevent their development. And clinical studies have identified numerous risk factors for postoperative pulmonary complications, the most frequent being older age, poor lung function, smoking history, and COPD. And I'm showing here 2 guidelines on the selection of patients with lung cancer for surgery, one from the British Thoracic Society, and the other is a statement from the American College of Chest Physicians. And I won't go through these in detail, but the point that I want to make is that these guidelines, they recommend preoperative lung function assessment by pulmonary function testing, and that both FEV1 and DLCO be considered in risk stratification and decision to resect. And neither guideline recommends lung function assessment by ventilation imaging, and it's very rarely performed clinically for this indication. But if we revisit the risk factors that I introduced on the previous slide, we know that in patients without lung cancer, all of these risk factors have been associated with abnormal ventilation that's been assessed by various ventilation imaging modalities. So this really presents a unique opportunity for Technegas SPECT. And towards this opportunity, we've designed a 6-week prospective observational study to address 2 research questions. The first being, what is the prevalence of abnormal ventilation quantified by Technegas SPECT prior to lung cancer resection? And the second being, does preoperative ventilation quantified by Technegas SPECT predict the occurrence of postoperative pulmonary complications or clinical outcomes following resection surgery? And to address these 2 questions, we're enrolling patients at the time of a resectable lung cancer diagnosis. They then undergo Technegas SPECT about 1 week prior to the resection surgery. And then we follow them for 4 weeks post-operatively to document their post-operative pulmonary complications and also their clinical outcomes. So the data I'll be presenting today is an interim analysis of 72 patients who have completed the preoperative assessments. Former smokers, with only 17% being never smokers. And if we look at the history of concomitant lung disease, we can see that 11% of patients had asthma, 28% had COPD, and 60% had no history of lung disease. So I'm showing here now 3 representative patients who underwent ventilation SPECT prior to lung cancer resection surgery, and I'm just arranging representative coronal slices from the posterior to the anterior of the lung. And this first case was a 62-year-old female with no history of lung disease, stage 1 non-small cell lung cancer. They had normal spirometry, so normal FEV1, a normal FEV1 over FVC, and a normal diffusing capacity, or DLCO. And these numbers agree quite well with what we visualized with ventilation SPECT. We see this nice homogeneous distribution of the Technegas within the lungs and no large ventilation defects. This 81-year-old male, again with no history of lung disease, but now presenting a contrasting case with respect to their ventilation. So despite having comparable and normal FEV1, FEV1 over FVC, and DLCO, we see a dramatic difference in the ventilation between these two cases, noticing significant heterogeneity in the upper lobes of this patient and multiple focal ventilation defects within the lung. So this highlights the sensitivity of Technegas SPECT to subclinical lung disease, which I believe is actually the focus of the next talk. And the final case I want to highlight here is this 65-year-old male, COPD, stage 3 non-small cell lung cancer, abnormal spirometry, and modestly reduced DLCO. But what's quite striking about this case is the right lung predominance of ventilation defect in this patient. So we'll come back to these later. Just trying to advance, there we go. So similar to what Dr. Maksym very elegantly explained in the previous talk, so I'll briefly go over this, but we also quantified ventilation abnormalities in these images using the ventilation defect percentage, or VDP. We used an adaptive thresholding method that was developed quite a few years ago by Catherine Farrow and Greg King from Australia. And as Dr. Maksym mentioned, this is a very intuitive biomarker where we determine the ventilation defect volume from SPECT, and this is normalized to the lung volume determined by CT and expressed as a percentage. And I'm showing here the raw SPECT image and the corresponding segmented ventilation mask for a healthy volunteer and a patient with COPD. And the black regions shown here within the thoracic cavity volume were classified as ventilation defect, and in this occupied 12% of the healthy lung and 62% of the COPD lung. So a higher VDP is reflective of a higher ventilation defect burden. So we evaluated if Technegas SPECT VDP was sensitive to underlying lung disease in our population. And what this plot shows is that there's a greater ventilation defect burden in patients with COPD compared to those with a history of asthma or no history of obstructive lung disease. And there was no difference between the asthma and no history groups. And these correlation plots show that the defect burden quantified by Technegas SPECT is correlated with FEV1 over FVC and a DLCO, again, which are our standard clinical measures of airflow limitation and diffusing capacity. Okay, so what is the prevalence of abnormal ventilation prior to lung resection? So answering the first question that we asked. And what this plot is showing is the preoperative Technegas SPECT VDP for all 72 patients that we've evaluated. And we established an upper limit of normal threshold based on an independent healthy control population that was imaged at our center. And this is shown here at about 17% VDP. And what we observed was that 53% of participants had abnormal ventilation prior to lung resection surgery. So 50% of patients, which is quite compelling. And of this, 45% of those had no history of lung disease, and 24% had normal FEV1 and normal DLCO. So we were quite intrigued by this high prevalence of abnormal ventilation in patients with no history of lung disease and those with normal lung function according to standard lung function tests. And this was the case for the 81-year-old male that I had introduced to you. But really the important question is, what is the clinical relevance of this? Is this abnormal ventilation that we're detecting using Technegas SPECT VDP important to patient outcomes? So this is what we asked next. And to evaluate the clinical relevance of preoperative abnormal ventilation, we've been meticulously evaluating postoperative pulmonary complications and patient outcomes. And I'm presenting that data here. So far, 13% of patients have had a postoperative pulmonary complication, and that could have been atelectasis, acute respiratory distress, ventilator support, and or pneumonia. And the median length of hospital stay in our cohort was 3 postoperative days, but we can see this wide range of 1 to 26 days. 15% of patients had to present at the ER visit post-discharge, 7% were readmitted to hospital, and unfortunately, there's been 1 postoperative death. So let's revisit the 3 cases that I'd introduced to you earlier, and here are the resection details for these patients and their clinical outcomes. So I'll walk through these cases one by one. The top patient with normal ventilation had a left upper lobe wedge resection, and she did very well, spent only 2 days in hospital with no complications. The comparative case with abnormal ventilation had a lingulectomy and had a more complicated postoperative period that required 6 postoperative days in hospital, and they subsequently presented to the ER with pneumonia. And the final patient with COPD and this right lung predominant defect ended up requiring a left pneumonectomy due to the invasiveness of their cancer. He had a prolonged postoperative ICU stay and ultimately passed away due to respiratory failure. And what I think is quite important to highlight here is that with the prior knowledge provided by ventilation imaging, which very clearly reveals that this patient's lung function was localized to the left lung that was being resected, this gentleman's treatment plan and outcome may have been quite different. So moving away from cases, now let's look at postoperative length of hospital stay in the population at large. So what this plot shows is that patients with abnormal ventilation spent more days in hospital than those with normal ventilation. So the normal ventilation group spent 2 days in hospital, and patients with abnormal ventilation spent double that, so 4 days in hospital. Now, considering Technegas SPECT VDP as now as a continuous variable, we observe this nice positive univariate relationship with increased length of a hospital stay. And while this is quite encouraging, it's really most important to consider the predictive value of VDP relative to known risk factors. So we evaluated this by generating a multivariate regression model. And the results of this were quite compelling, revealing that Technegas SPECT VDP was an independent predictor of postoperative length of hospital stay, having a greater impact than known risk factors, including age, smoking history, COPD, and standard lung function metrics of airflow obstruction and DLCO. So we're quite excited about this. And I'll wrap up now by summarizing the results of this interim analysis. We're reporting that ventilation defect burden quantified by Technegas SPECT VDP is increased in patients with COPD and correlated with standard clinical measures of airflow limitation and diffusing capacity. Abnormal ventilation was detected preoperatively by Technegas SPECT in 53% of patients, 45% of whom had no history of lung disease, and 24% of whom had normal DLCO and FEV1. And finally, that higher Technegas SPECT VDP was an independent predictor of postoperative length of hospital stay. And the conclusions we're drawing at this point are that abnormal ventilation quantified by Technegas SPECT VDP is prevalent prior to lung cancer resection, and that Technegas SPECT VDP might be an independent and most importantly, stronger predictor of postoperative length of hospital stay than established clinical risk factors. So there's clearly, in my opinion, some potential here for clinical impact, specifically by identifying and modifying risk factors such as abnormal ventilation in lung cancer patients prior to resection surgery may allow us to reduce the incidence of postoperative pulmonary complications and improve postoperative lung health. And our next steps towards this are obviously to finish enrollment for this study, at which point we should be sufficiently powered to assess additional outcomes that Technegas SPECT VDP may predict, including death, ICU stay, ER visits, and various other specific complications. And if the results of our prospective observational study are indeed found to be positive, there'll be strong rationale to conduct definitive RCTs to determine if the integration of Technegas SPECT into the standard of care workup for lung resection would improve patient outcomes. And I think the specific roles that we should target are of course, risk assessment and modification, but also treatment planning, where we can leverage the regional ventilation patterns to inform the extent of resection or to provide evidence for the need of alternative treatment options such as chemotherapy or radiotherapy. And I'll end there by thanking everyone on this slide who's contributing to this work and making it possible, and thank you for your attention.
Well, thank you very much for a very interesting and what sounds like really quite positive findings. It's wonderful. Congratulations to your group and continue the good work, and we look forward to seeing the final product. Our final speaker of the day is Dr. Daniel Juneau, who is from Montreal. He did both his MD and specialty training in nuclear medicine from the University of Montreal, followed by a 2-year multimodality thoracic imaging clinical and research fellowship at the University of Ottawa Heart Institute. He's currently the head of nuclear medicine at the CHUM in Montreal, as well as the medical director for the cyclotron and radiochemistry unit there. So without further ado, look forward to your presentation, Daniel.
Thanks a lot, Andrew. It's a pleasure to be here, and a big thank you for the invitation. I'm going to share my slides. If somebody could let me know that it's working well.
All good.
Wonderful. All right. So quantitative lung ventilation using SPECT-CT, a potential tool for detecting early small airway disease. So disclosures, I'm a consultant for AAA and Novartis, completely unrelated to this work. Background. Okay, so COPD, as you all know, is one of the most important cause of hospital admissions amongst chronic disease in Canada. It's associated with significant morbidity, significant mortality, and significant social and health costs. We do know that ventilation heterogeneity is one of the hallmark features of most obstructive pulmonary disease. And currently, when you want to diagnose COPD, that's based mostly on the results of pulmonary function testing. One thing, however, is that a significant number of active smokers will demonstrate clinical features of COPD. For example, that could be dyspnea, chronic cough, lower exercise capacity, self-reported, airway inflammatory cellular infiltration on pathology, but they don't meet the PFT criteria for COPD. And what's interesting is that some of these patients will actually go on to meet the criteria, but others will not necessarily, okay? So a few years back, another group demonstrated an interesting technique which we're building on. So I'm going to talk quickly about what they did. So Norberg and his group in 2014 recruited 14 healthy subjects and 2 patients with documented airway disease. And they all underwent SPECT-CT with Technegas, pulmonary function testing, and a health questionnaire. On the SPECT-CT, what they did is they segmented the lung volume as defined using the CT acquisition. And then they processed the SPECT, the segmented lung volume, to calculate coefficients of variation for overlapping 1 cubic centimeters volume. So basically voxels, okay? And this is kind of what this is the graphical representation of that. So basically on your on this axis, you have the coefficient of variation, and on this axis, the vertical one, you have the lung volume fraction density, so the abundance of said coefficient of variation. And they said what we're going to do is we're going to define a cutoff. They used a cutoff of 20%. So, and they calculated the area under the curve for a coefficient of variation above 20%. Okay. So, and this volume here, that's what you're seeing. Okay, in light green. And what they showed was that the patients with abnormal PFTs at higher area under the curve values when compared to healthy subjects. So basically they had more voxels with a high coefficient of variability, so a higher heterogeneity. So building on that, we set out to see if Technegas SPECT-CT could potentially provide clinically relevant information in smokers, but with normal pulmonary function testing. So what we did is we prospectively recruited 30 subjects, all of which had normal PFTs. So that all of it. So they had everything had to be normal. So FEV, FVC, the total lung capacity, the residual volume, the inspiratory capacity, all of it. Of these, 15 were smokers. That was defined as at least 10 cigarettes per day and a total smoking history of at least 15 pack years. and the other 15 patients were non-smoker. Actually, they were what you would define as never smokers because they had to have a maximum lifetime history of less than 5 cigarettes or cigar. We excluded pediatric patients, pregnancy and breastfeeding were exclusion criteria, any abnormal PFT, of course, and we also excluded anyone with a self-reported history or a demonstrated diagnosis on file review of COPD, asthma, cystic fibrosis, bronchiectasis, interstitial lung disease, pulmonary hypertension, lung cancer, lung resection, or pneumothorax or any other pleural disease. So anything that we thought could influence the results of what we were doing, basically. So we wanted people with normal lungs as much as possible. So this is the demographic and the clinical characteristic of the subjects in both groups. The groups were well matched. The only significant difference between both groups were here. So we had the FEV1 was slightly higher in the non-smoking group compared to the smokers. They were all normal, right? But again, the never smokers were slightly more normal, you could say. The one other thing that was different between the groups was that the MMRC score was higher in the active smokers when compared to the never smokers. The MMRC is the Modified Medical Research Council Dyspnea Scale. So it's a questionnaire basically where you answer questions, and it assesses your self-reported dyspnea. So the smokers had scored higher on that. So after that, we performed Technegas SPECT CT in all subjects. It was performed within 48 hours of their PFTs. We used the standard inhalation technique. We used a lower threshold of 4,500 count per minute at the anterior chest wall right before proceeding to imaging. We processed the image to obtain 3D coefficient of variation maps, and we derived from those area under the curves for coefficients of variation greater than 40%. All imaging processing was performed by staff that was blinded to the smoking status. And this is what it looks like, basically. So these are images from 2 representative patients. Image A and B are from an active smoker, and image C and D are from a never smokers. And basically what you're seeing here, so these are, of course, the Technegas images in row B and D. And in A and C, you have the derived coefficient of variation maps. So basically each voxel has a value, and these are represented using color here to make it more visually interesting. And low coefficient of variation voxels are in green, intermediate ones are in yellow, and high coefficient of variation voxels are in red. And you can see straight away, just looking at these 2 patients, there's a lot more red in the smoker than in the never smoker. But don't take my word for it. This is the actual values for both groups. So you see the spread of the AUC in the active smokers on the left and the never smokers on the right. And you can see straight away that there's a difference. There is the value of the AUC was significantly higher in the active smoker group when compared to the never smokers. The values are right here at the bottom, and the p-value was quite significant. It was of course significant, and you can see that there's more also heterogeneity in the active smokers. We get more of a spread of values, while the never smokers have a more tightly grouped, like the values are closer, there's less heterogeneity in the distribution. What was also very interesting when we analyzed the data is that the values of AUC, of area under the curve for the coefficient of variation 40, they correlate with the self-reported dyspnea. So these are the patients who had an MMRC score of at least 1, and these are the ones with an MMRC score of 0, right? And you can see that the p-value, when you compare them using the AUC, there's a significant difference between both groups. So that's interesting because it means that this heterogeneity that we are seeing relates to self-reported symptoms of dyspnea. We also looked at DLCO and FEV1 were related to this. They're not, but maybe it was a power issue because this was a small exploratory study, and the p-values didn't reach significance, but they're not that far off either. But again, this was quite significant even in a small cohort like we used. A few other interesting findings that we had, the values that we found of AUC-CV40, they were not linearly correlated to the cumulative smoking history in PAC years. So that's interesting because we do know that there's many factors in play when it comes to the amount you smoke and your propensity to go on to overt COPD. There's a question of genetic predisposition, of the way you smoke, and so interestingly, our values are not necessarily correlated to the cumulative smoking history, which makes sense. And then there was a significant relationship between the values of AUC-CV40 and the FEV and the LCO, which is unsurprising as Norberg already demonstrated that in the past. So what conclusions can we draw from this? So basically, what I think we've shown is that there's a significantly greater regional lung ventilation heterogeneity in smokers versus never smokers, even in the presence of normal PFT. And I think that's the part that's really important, okay? And we can use Technegas SPECT to measure this phenomena. The degree of heterogeneity also appears to be related to respiratory symptoms, which is very interesting. And so what are the next steps with this? So maybe we can use this new technique in the future as a prognosis indicator in smokers, possibly. Or maybe we can even potentially use it to predict which smokers will go on to develop full-blown COPD. And maybe we can use it to also understand the response to some of the therapeutic interventions that we're using in this patient population. Of course, this is one study, it's a small cohort, but still it raises a lot of interesting questions. And a big shout out to all of my collaborators who made this possible. Of course, this was a team effort. And thank you for your attention.
Well, thank you, Dr. Juneau. That's another interesting take on the use of this imaging agent in other clinical scenarios. I just want to make sure I'm not seeing any questions in the board at this point. Just have to turn to where, if there's any questions anybody has, you can fire it at us here now. Otherwise, I'm going to invite all partakers back. If Dr. Maksym and Dr. Svenningsen could come back onto the screen here for a second, and we'll just have a little roundup. I want to thank you all very much for taking the time out of your days and presenting this exciting research. I think the thing that I would ask, because I've been involved in one of these projects, for each of you folks, the stuff that you're doing, I mean, Technegas and the availability of this agent in general imaging nuclear medicine departments across Canada is pretty robust, unlike our neighbors to the south, who kind of live in a more retrogressive space, as we know. I want to know from your perspective for each of you, just to kind of quickly say, how generalizable do you think, if what you're showing us today, each of you seem to show some very promising results for using this technique in a particular patient population, to the general nuclear medicine population, how do you think, particularly from the standpoint of the biomedical types, to be able to generate the kind of information that you're generating to help? Geoff, take a shot at it first. In other words, you've taught me to do some of this stuff, and I've done some of it. And I mean, I feel relatively. I mean, the you've used MATLAB and some other sort of specialized programs in order to generate the various things. But do you think that we can make this a little more understandable, I guess is the word I'd use, so that we can take the technique into the clinics?
Well, I think the big switch is that it's not just looking at structural differences like CT would be looking at fibrotic areas, ground glass, nodules, these sorts of things, whereas functional imaging is what SPECT CT is. You're looking at where ventilation goes versus where it doesn't go. And so you're looking at physiology. Your question is about access. So first, you have to understand that you're looking at function in these images. You're not just looking at the structure. Of course, the function follows what might be happening with the structure if it's narrowed or obliterated airway, such as in my particular case. But yes, we were able to develop our technology so that it would be easily usable on the Hermes workstation, which was available in the QE2. And so a little bit of instruction of the radiologist looking at the SPECT CT, and they could quantify the images in the same way, look for the hot spots and take repeated images of individual patients if they're looking at following a particular patient for, trying to understand what's wrong with their lung function better.
All right, and Dr. Svenningsen, what would your take on that be, taking it to the clinic?
I agree with everything Geoff said, and just maybe a couple points to add. Speaking specifically to the translation of these quantitative biomarkers, I think the scientific community probably needs to do some optimization of the pipelines to generate these measurements. We've kind of selected thresholds based on some evidence, but I think a well-designed study to understand the optimal threshold, also evaluating inter and intra-observer variability. I think those are key low-hanging fruit studies that we can take on together, and that would be quite helpful if we were considering translating these quantitative measures to the clinical space.
I think it was my perception. I mean, as a nuclear medicine physician and imager, looking at the images I see from what Geoff and we have been doing, is you can certainly kind of gestalt this person has troubles, but the quantitative measures, particularly in terms of serial things, is very helpful and that sort of thing. Daniel, do you have any comments in this regard? You're another imaging type.
No, I completely agree. I think we need all of these applications are interesting. They're novel, right? We'll need more data because before these things go to prime time clinical use, of course. Like I wouldn't argue that we need to start screening smokers complaining of dyspnea with the SPECT CT Technegas tomorrow. We're not there, not at all. But there's definitely something, and this is a technique that we've had for a long time, and obviously we haven't squeezed the lemon yet for all the juice in there, right? And there's more to get out of this for sure. And speaking for our work at CHUM, it's not complex. It's what I mean is a lot of it is automated, and yes, it would be scalable to lots of sites. But I completely agree with Sarah that we'll need a little bit more data regarding some of the numbers and the cutoffs and everything, because you can't just take 30 patients and say that's it. Like our AUC 40, the 40% was kind of arbitrary, right? We need more data before we really say this is a proper cutoff, right?
I guess the other thing I'd just sort of say, Daniel, is, we look at these things day in, day out. I mean, VQ SPECT is standard of care. So it's not, and each and every one of certain, and Sarah, I'm sure yours is the same. This is just a routine clinical application. We're not doing anything fancy here. So just being an imager reading a VQ scan for another reason, it kind of heightens the way you may look at the image in a little more of an eloquent way. Well, I think you guys have done an absolutely fantastic job, because nobody has had a question to ask beyond this. So I think that's fantastic. Again, I want to thank you all for taking the time to present this exciting data. I think it is kind of a new look at an old warhorse that we've had. I want to thank everybody who's been on. We've had a tremendous turnout in terms of the tuners into this. I also want to remind you that we have another one of these coming up in a week or so, or a few weeks. Dr. Jean-Luc Aubin is going to be talking about theranostics, another very interesting and current topic, and we'll look forward to that. So I think at this point, Hamidi, do you have anything else to say? Do you want to chime in with us here? And
yes, I know we are reaching our 1 hour mark, but we have few questions. We just got like 3 questions that just got shut out. So
okay.
if you don't mind staying a little bit longer to
go ahead.
address them. The first question, Dr. Ross, can you see the questions? Oh no,
I'm not seeing the. I'm going to get you to. Okay. There's something going on here, Hamidi, that I'm not seeing them right yet.
No problem. I can actually. So first question, which has the prognostic better between abnormal perfusion or abnormal ventilation with post-operative length of hospital stay? This is a general question addressed to everyone.
I think this would be for Dr. Svenningsen by the sound of it, by the post-operative nature. Sarah?
I think the question was, and correct me if I'm wrong, what has the better post-operative predictive value, ventilation or perfusion?
Yes, that's exactly what the question is. Yeah.
Okay, so in our study, we're only acquiring ventilation, so I can't comment on perfusion at all in our data set. And I'm not familiar enough with other literature to kind of speak to that any further, but we're kind of shooting ourselves in the foot that we didn't do a VQ scan on these patients. Anyway, we'll be able to hopefully, moving forward, we would integrate the Q side of things as well.
I'll ask the second question here, Hamidi. I found it. They're buried on my system. I'm sure you do an admirable job. This is for everybody. Someone's asked the question, would you see, if you don't, most of us are talking about absolute quantification with an SUV value, in other words, quantification of these images. Our systems here, Geoff, don't have that capability. I don't know if the other folks do or not, but do you see any added value of that measure into the stuff that you've been working with? And if you don't, it's an interesting question. It's another application.
That's the actual dose of radiation.
It's more of an absolute measure of the tracer delivery to any given area. Yes. Yeah.
It's actually, what you're looking at is a reflection of the tracer that's present in your image. You can sum up the total image intensity and get that. And you also have the dose when you calibrated, when they inhale the Technegas, the technologist usually does it to achieve a minimum level of dosage, and you get a rough estimate of how much is there. So I think it's maybe a standardization when you're comparing between different centers, and that can be very helpful if we're looking for comparative work. But maybe within a patient, when you're following the same protocol, it's not actually necessary.
Yeah. Any further comments on that?
No. For the work that we did, it wouldn't help, because we are really looking at coefficient of variations in between voxels. So any kind of absolute quantification will not really provide additional information.
That was the general feeling I had from the work we've done here as well. The last question, as far as I can see, for some reason on my screen, it is the smallest print I can ever imagine reading. The last question was another one more directed at Sarah, and it was asking about perfusion imaging. We use standard pro-evaluation in certain patients with lung resection planned is an MAA perfusion scan. So it was another question directed at that. But as you say, that wasn't part of your study protocol with what you did. So I don't think it's. I think you've already answered that. So I think.
I do just want to quickly comment on that. At our center, our center performs one of the most resection surgeries in Canada, lung resection surgeries, and we do not do any ventilation scans on those patients.
All right, Hamidi, I think I've covered off the questions that I can see.
Yes.